Hi, it's Andrew here, and this is Coding Matters, where we talk about how medical and clinical documentation impacts the way we are performance measured and financially made sustainable through clinical coding. Today I want to talk briefly about the main changes that have come to the ANSNAP version 5 classification as we move from version 4. In case you don't know, that's the Australian National Subacute and Non-Acute Patient Classification System. And as I say, we're on to version 5. This covers patient care that is non-acute and subacute, like in its name. They're things like maintenance care, palliative care, rehabilitation, and geriatric type care under the Geriatric Evaluation and Management Unit, or also called GEM or GEMU. The main change in version 5 has really been for that latter group, the geriatric group, the GEMU admissions, particularly those that are overnight, which is the majority of GEMU admissions that I'm aware of in Australia. The shift has been to using 3 main classes of frailty under the Frailty Related Index of Comorbidities, or FRIC classification. They've split this up into these 3 groups depending on the number of points you get towards that FRIC score, and then within each of those 3 classifications there is a subsection. So a little bit like having a DRG and then having a minor or major complexity. This has 3 FRIC classifications, and then within that a kind of level of complexity determined by their FIM score, which is their functional independence measure. That part hasn't changed, but the FRIC part is new. There's a number of things that can contribute towards your FRIC score, and therefore in which of those 3 classifications your patient will sit under. Most of them relate to chronic conditions, particularly around cognitive impairment. Some of them are related to acute conditions, but a lot of acute conditions have been excluded from this particular classification system under ANSNAP 5. Things that used to count but don't count at all towards the FRIC score are vitamin D deficiency, mineral metabolism or electrolyte abnormalities, and deconditioning, which was one of my previous big go-tos if you've watched my other videos. The things that count a lot are dementia and delirium, intracranial injuries that are not recoverable, urinary tract infections, arthritis, spinal issues, and osteoporosis. Let's look at those main items that really count, which we really need to emphasize when we're doing our documentation and avoid missing out on. In terms of the high scorers, dementia, particularly Alzheimer's dementia, not Alzheimer's disease, will get you 7.1 points. That's the highest score in any of this FRIC classification. Importantly, if we're managing this person in a hospital, they don't have Alzheimer's disease, they have Alzheimer's dementia, and there's a distinction between the two of them, one of which the dementia part is having a big impact on their daily living, and the disease is usually a sign that it's very early and isn't having a big impact. Vascular dementia and other unspecified types of dementia still count in the order of 2 points. Delirium also counts, as long as it's not substance, alcohol, or medication-induced delirium, which is seen as reversible. But other forms of delirium do count for 3.2 points. Cerebroarteriosclerosis, if you document like that, which is generally what we equate the clinical diagnosis with the imaging finding of small vessel disease seen on CT or MRI, also counts decently, and we see that at a high prevalence, so don't miss that out when it's relevant for your patient. Intracranial injuries all count, except for concussions, because concussions are generally recoverable. So that includes intracranial bleeding, hematoma, hemorrhage, in any kind of fibrosis, any kind of brain tumors and the like. Anything that's there that is potentially permanent damage will count, and so should be documented as specifically as you can be. And they include such things as cerebral edema and diffuse brain injuries, contusions, hematomas and the like. Urinary tract infections still count, and in fact catheter-associated UTIs count as well, so don't miss out on them, which are very prevalent in the geriatric population, especially those that you will find admitted in hospital. Osteoarthritis counts, but you can't just write osteoarthritis, you need to specify which site. So for osteoarthritis of bilateral hands, osteoarthritis of the lower back, these things count. Osteoarthritis of the hip, of the knee, as long as you can be specific about a site, it can be coded, but just generically osteoporosis isn't specific enough, so make sure that you are documenting appropriately. Scoliosis of the spine counts. Osteoporosis, as long as you're specifying the location, can count towards the FRIC score as well. And any kind of spondyloarthropathy will also count. Interestingly, although a lot of acute conditions are excluded, dehydration or volume depletion still counts for 2.3. There are a number of other items that are semi-prevalent in this population. They may not be high scorers by themselves, but with a few of them or complementing some of those high scorers, they will count as well. So things like visual impairment that is enough to be causing blindness, Parkinson's disease, vitamin B deficiency, pressure injuries, hypotension, sepsis, and epilepsy all count. And although the points themselves will mostly land them at a singular level in the lower classification, once you have a few of them, the patient will easily fit the medium and higher classifications. So what hasn't changed in ANSNAP 5 is all of our standard quality documentation practices that are always going to value add, regardless of what type of classification you're sitting under. They are causal relationships. Causal relationships specifically using phrases like due to and secondary to, not background of or context of, that are not explicit enough to be coded. It's not my rules, it's the rules that the coders have to work under. So let's help out as clinicians who document for coding. Also, the more specific diagnostic terminology you can use, the better. Particularly relevant to this group, cognitive impairment is not codable. Mild cognitive impairment is not codable. Mild cognitive disorder, because it's an ICD-10 classification, is. And dementia or major neurocognitive disorders are. So if you've got some memory impairment, you've got some memory problems, you've got cognitive impairment, specify a likely or probable diagnosis which can later be confirmed, and that will really benefit the patient and their documentation and better represent the diagnostic journey that they're undertaking with their clinicians. Always make sure to justify with diagnostic terminology terms like functional decline and deconditioning. There's always an underlying cause, even if it's not yet fully confirmed, so you can use terms like probable or likely or suspicious to quantify some of that diagnostic uncertainty whilst you're investigating them towards a diagnosis. I hope that's been helpful, and if you want to hear more about other elements of classification, let me know in the comments below. See you soon.